So what I have done is I didn't open it. I left the tiny secustum there because there was no infection, no sinus. It was only X-ray wise there is a secustum. And accepted his sclerotic bone ends, just corrected his deformity very, very slowly. He corrected it himself and started walking. And complete healing in pure distraction. See that what happened to that secustum? What happened to that sclerotic bone? So it is not the X-ray, it's the clinical judgment is more important. That is before, now you can see he has become single knee now. He had two knees earlier, now single knee. But whereas this case is not like the other one, that was a stiff non-union. This is a little bit laxity. This is called type 2 stiff non-union, which will have about 15 degrees of movements. The other one will have about less than 7 degrees. So these may not heal by distraction. It is more lax, periosteum is not strong enough. So what we can do, you can convert type 2 to type 1 by a 3 to 6 weeks of compression. So I just compressed it and then distracted it. So I converted type 2 to type 1, kept it for some time, for 6 weeks. Then I distracted very slowly. It healed well and got his length back. Whereas here, again, he had more than 2-year-old non-unions, more than 12 surgeries, he lost everything. And double non-union. Actually, he came to me for amputation. It was a type 2 stiff non-union. It may not respond to distraction alone. And you have a tendency to excise the whole piece out and do corticotomy and transport. But I resisted myself. He begged any treatment other than Illusorov. I don't want Illusorov from his bad experience. So I put a fixator, somehow convinced him and put a fixator on that with no sinuses on both sides were there, no safe place for corticotomy. Oleo wires were not holding. So I custom made twisted oleo wire and all compressed. He started walking on 3rd day. So in 4 months, this was the result. It just melted and healed each other. So now we go on to atrophic non-union, which are lax non-unions. Here the periosteal healing is incomplete or lost. There is a vascular problem or there is a big gap. There is no joint formation. Though it is called pseudarthrosis, there is no joint here. It has demonstrable multi-directional translational movements like this. You can move it to any directions. Because there is no contact between these two. So we have 2 types of lax non-unions. One is a synovial pseudarthrosis. The other is an atrophic fibrous non-union and infected non-union. In Illusorov method, the principles of treatment of all these are the same. So we don't differentiate all these. All these need debridement and that converts into a gap and the management is gap management. So you make a gap, remove everything. So the indication for making gap is if you don't like the shape, you have to remove secustra, if you have to put bone graft. So this is it. If you don't like these shapes, you change the shape like this. This is a good shape. This is stabilizable one that increases the intrinsic stability. In Illusorov, we have 3 modalities of treatment: monofocal, bifocal, and complex. Monofocal you have already seen. Now I go into the bifocal treatment. And there's a thinking that corticotomy heals the fire, infection heals the fire of regenerate. It's better not to rely upon this fire. The indication for a corticotomy is to get length. It mostly works like a defunctioning osteotomy. So this case, you can see the lower tibial gap, poor stability. I made a frame and stabilized it, postoperative correction, and you can see a bent frame and a straight leg, and it's completely healed. Now we have a trifocal transport and transverse. Like here you can see a double transport, and that is how it has healed. Now that is a function. Now the internal bone transport is oleo wires. The other one was external transport, and that is the result. When the gap is more than 10 centimeters, then you can probably do a fibular transfer like this and get a good function. So the most important part is, it is not the fixator, but your strategy which heals the non-union. Make a good stable frame to implement it and help the bone to heal. Thank you.
Thank you, sir. Thank you, Dr. Vasudevan, sir, for your excellent enlightening talk on the management of fractures.
So before that, I call upon Professor Uday Kumar Garu to hand over a gift of appreciation to Dr. Vasudevan Garu. Sir, I shall hand over your certificate by evening, sir.
Okay, sir. Thank you, sir, for your enlightening talk. Now I request our professor, senior professor, Dr. C. Hanumantarao, on his excellent talk on infective non-union.
So welcome to Dr. C. Hanumantarao Garu. His talk is going to be on infected non-union. Thank you. I request the technical team to be more alert, please.
ఓకే ఇది క్లోజ్ చేయలేదు
ఎలా చేయండి మేక్ ఇట్ ఎలా Good morning. Thanks for the organizers for the opportunity given to me. Respected chairpersons, today my topic is infected non-union, which is a real problem to the practitioner. As everybody knows, when there is no clinical or radiological union of a fracture, even after 6 to 9 months we call it as a non-union. Everybody knows that. When the infection persists over non-union, it's going to be much more problem to the orthopedic surgeon as well as to the patient. So most of these infections are acquired because of trauma and post-operative infections. It's not moving, you know? What are the consequences of infected non-union? Multiple sinuses, interruption of blood supply results in sclerosis and dead bone. Sclerosis is a dead bone. Stiff joints, limb-length disparity. Large bone gaps leading to gap non-union, as our Vasudevan told. Drug resistance infecting organisms and complex deformities. So what are the causes of persistence of infection here? Thrombosis of aversion canals, blocked medullary cavity, fibrosis of the tissue with bacteria, inadequate antibiotic perfusion, mobility at the fracture site, and biofilm. How infection results in non-union? Extension of pus in different planes, periosteum with loss of blood supply, catabolic response at the fracture ends leading to sclerosis, inflammatory mediators providing fibrous tissue ending in fibrous non-union, in fixation, implant failure, destabilizing the fragments. These are all the different organisms everybody knows. Of all the organisms, Staphylococcal aureus is the most common. A word about biofilm. Once the infection sets in following an implant surgery, the organism becomes resistant to host immune response as well as antibiotics because of the formation of biofilm. Biofilm protects the organisms from antibiotics and host defense mechanism. The presence of implant becomes another source of infection. These are all the classification of infected non-union, infected non-draining non-union, and infected draining non-union. Kulkarni has given classification depends on severity of infection, apposition of fragments, and presence or absence of deformity. Again divided into type 1, type 2, type 3, depending on the involvement of the bone, 3A, 3B, and 3C. This another classification depends on the extent of infection. Another classification based on the host, based on the anatomy and clinical stage. These are all different classifications for interest sake for the juniors as well as postgraduate students. These are all the routine investigations we perform in the infected non-union case. What are the suspected areas of infection on X-ray? This question will be asked to the postgraduates routinely. Bone resorption, bone cysts and lytic areas in the bone. Sequestrum, cavity formation, and involucrum, provided there is an established case of osteomyelitis. Periosteal and endosteal new bone formation and cortical irregularities. CT scan give better cortical details. Sequestrum is clearly noticed. Subtle cortical changes are seen. Best details of bone structure for planning. MRI, as you know, is highly sensitive to the extent of 98%. Gadolinium enhanced MRI will definitely discriminate between active infection from artifacts. Demonstrate sinus tracts, differentiate bone and soft tissue infection, and extent of bone involvement for planning of surgery. Radionuclide imaging is another method of investigative modality in which for diagnosing periprosthetic joint infection. These are all the different types of nuclear imaging studies. Technetium 99, gallium 67, iridium 111 labeled WBC scan. Culture is the gold standard, as you all know. Multiple intraoperative specimens, sinus tract, purulent fluid, soft tissue is curated and sent for culture. Prior antibiotic treatment and improper handling of specimens may definitely alter the report. The clinical features of non-union being, everybody knows about pain and mobility at the fracture site, local rise of temperature, chronic discharging sinus, scar healed by secondary infection with puckering, irregular thickened bone showing chronic osteomyelitis. Delayed late infection clinical features being hallmarks of delayed infection, pseudoarthrosis, implant loosening, development of a sinus tract, mainly caused by microorganisms of low virulence. So coming to the treatment depends on multiple factors such as type of infection, isolated pathogen and its susceptibility pattern, the fixation of the device, quality and availability of the bone stock, and training and, of course, experience of the surgeon. Treatment goals being increase host resistance, eradicate infection, achieve union, solve soft tissue problems. How to increase the host resistance? By morbidity correction, blood sugar, smoking, liver and renal problem correction, improving nutrition, treatment of comorbid condition. Naturally, systemic appropriate antibiotic therapy is to be started. The supportive methods to achieve bone union, improved delayed union. These are all the things: aspirated stem cells, DBM, autogenous cancellous graft, growth factors, external stimuli like ultrasound therapy and electrical and electromagnetic therapy. Goal 3 is very important. Soft tissue problem, transfer of vascularized muscle tissue definitely improve the blood supply. It improve the host resistance, improve the antibiotic delivery, and osseous and soft tissue healing will be improved because of vascularity. Deformity correction, Elizero is the gold standard, as in detail told by my friend Vasudevan. Treatment non-operative being ultrasonography, electrical, electromagnetic stimulation, biology, as I told you already, mechanical stimuli. Early weight bearing, maturation of callus will be formed. Axial micro motion as Ashok Kumar highlighted, accelerates healing. Definitive method being to obtain early union naturally to reduce the short of convalescence, preserve mobility in adjacent joints, restoration of bony continuity. Bone union takes priority over infection, non-union exposure through old scars. Procedure being, the ends of fragments are decorticated subperiosteally, osteoperiosteal flaps, all devitalized and infected bone is removed, and fragments aligned by stabilized by external or internal fixation. Local control of infection is important to thorough debridement, suction drainage, negative antibiotic. Surgical modalities pertaining to the infected non-union, bone grafting and in infected non-union. You know, onlay bone grafting, single onlay and double onlay. In inlay bone grafting, wherein a groove is made between the bone nails. Antibiotic cement impregnated nail exchange nailing is very commonly used, economical and very effective. Gentamicin has been most widely used, followed by vancomycin. Antibiotic impregnated coated nail prepared in a customized mold, which can produce nails of varying diameter and smooth even surface consistently. The third is elimination of infection by Elizero method. If I tell in detail about Elizero method, Vasudevan may think otherwise. Muscular technique. Time is over. Excision of sequestrum. After 6 weeks, the spacer is removed. Formation of induced membrane is observed. Without disturbing the membrane, bone grafting is introduced. External fixation and definitive fixation is done. Consolidation of the gap is observed within 2 to 3 months. Local antibiotics by beads. Antibiotic bead pouch is placed at the fracture site. Biodegradable antibiotic beads and antibiotic impregnated bone graft. Criteria to retain implant. Acute symptoms 2 to 4 weeks. For stable implant with no signs of symptoms of loosening. Clearly established a single microorganism which is susceptible to bactericidal antimicrobial agent. Removal of implant may be needed. Pain due to implant, infection, nerve damage due to implant, non-healing of the fracture, implant failure with infection. These are all alternative methods. Time is over. This ultrasonography and electrical and electromagnetic stimulation is alternative to surgery. Summary, these are all the surgical modalities like antibiotic coated nail, bone grafting, Elizero external fixator, muscular technique, and antibiotic coated beads. Thank you very much for your patient hearing. Thank you.
Thank you, sir. Thank you, Master Hanumantarao Garu, for your enlightened talk. Now, the topic is open for discussion.
Let me call upon Dr. KRV Prasad Garu to hand over a gift of token gift for Professor C. Hanumantarao Garu. Thank you, Hanumantarao sir. Thank you, Dr. KRV sir. Thank you. So as our chairman has said, the session is open for discussion. As we are running short of time, probably we can allow 3 questions for each speaker. I request all the speakers to come out of the dais if they have any, if the audience have any questions. Anyone from the audience who have questions? Yes, sir.
So I have one question regarding Elizero. So it was a fantastic case which you showed that there was a sclerosis, which is a distraction. It went into good union. So how much distraction you should have? How do you calculate that distraction? Now, how do you know this is enough distraction?
Yeah, usually we give 1 mm per day, but in this case, 0.5 mm per day, that 0.25 mm BD. And you take an X-ray after 3 weeks to 1 month and see how they respond. then you can either increase it, but never go at a normal speed.
But then the distraction at the fracture site so as to get union.
Yes.
So how much it may be 1 inch distraction?
Now, usually it's an angular distraction.
Okay.
It is one, there will be two hinges which keeps in distraction mode. Distract from the other side, you calculate it so as to get 0.5 mm at the concave board. It's based on the rule of similar triangle.
So
Not
it's a
direct
correction of deformity as well.
Yes, it's basically a deformity correction. Not like most of the hypertrophy non-unions, it's a deformity correction, slow deformity correction.
Thank you, thank you.
Any other questions from the audience, please? So thank you. I think no more questions from the audience. I call upon Dr. Uday Kumar sir onto the dais to felicitate our chairpersons. Sir, please do come, sir. Thank you, Professor Uday Kumar sir. Thank you, Dr. Dharmarao garu, Dr. YVK Prasad garu. So let's switch over to session 2. May I call upon the chairpersons, please, Professor Ashok Kumar garu and Professor Uday Kumar garu. Dr. Umapati will be handing over the gift. Thank you. Thank you, sir. I request the chairpersons to take over the session, please. The thing is, the timing is 10 minutes for each speaker. I think someone was asking me the doubt. So it's 10 minutes for every speaker, you know. So please take over, sir.
So now may I call upon the first speaker, Dr. Satish Kumar, who is talk on the femoral non-union. I request all the speakers to stick on to the time.
Technical team.
The talk is on the non-union fracture neck of femur.
Good morning, all. I feel very honored and blessed to deliver a lecture in front of my indirect teacher, Dr. Uday Kumar sir, the person who introduced me to Ossapcon. So in last 3 years, I could not meet sir because of COVID and all those things. Otherwise, I used to meet sir regularly. So our non-union can be called as infective non-union because of COVID. Now the COVID has subsided, we can meet sir regularly. I would like to continue. The topic for today is non-union neck of femur. We all know the hip joint is the main weight-bearing joint of the body. Like the previous speakers have told, the US FDA definition is 9 months without signs of healing for 3 months is called non-union. but our neck of femoris specialist, it has only 3 months of time for union to take. So this topic we will be going to discuss under these headings, and why should we have interest towards this non-union? What are the causes of non-union? If at all happens, how to discuss the non-union, how to assess the non-union, what are the types, how to do the workup, and what are the invasive workup, and how to conclude the talk. So interest towards non-union. If you are practicing in medical college, if you are attached to an institution, if you have your own if you are attached to a corporate hospital, if you are having your own setup, the interest towards non-union will vary. But this is only with the interest of non-union. If you are working for a corporate hospital, I think medico-legal issues will score the first. And if you are attached to an organization like Uday Kumar sir or Ashok Kumar sir, it will be of academic interest. And to get a united fracture, you will get self-confidence. And if you are having good experience in practice, and if you are having good experience in treating of fractures, people will come for you the second opinion. So this lecture should help us to give a better second opinion and to good perform. And nowadays we are facing good number of Googlers who see the causes of fracture, the X-rays in the Google, and they come and they bombard us with good number of questions. So to brush up the knowledge, these conferences will help us, because failure will be very costly for younger patients. We should know about non-union, but ultimately the end user happiness. I feel the end user is the doctor. If he gets a good sleep, he can treat good number of patients. Most of the people might think that the end user might be the patient, but I feel the end user of the fracture is the doctor. So if you are a student to get a degree on non-union, the left side regions will be helpful. What are those? Absence of cambium layer, the synovial interruption, and secretory of some inhibitory substance, and the precarious blood supply. And the 7 is inadequate apposition, soft tissue interposition, infection, and improper implant, inadequate fixation. And if you tell these reasons, you will get a degree. But in the practice, there are so many other reasons for non-union. So that's why I've divided the causes of non-union when you are academician, and if you want to get a degree, and if you want to practice. The first and foremost is the failure to assess the fracture pattern, posterior comminution, undisplaced fractures, and WCNC signs. If you fail to see those fracture patterns in the first X-ray, and you will not be able to fix them properly, and it ends up in non-union. And if you fail to achieve an anatomic reduction, definitely it is going to become non-union. And inadequate fixation, and if the patient weight bears very early, and if you fail to see a fibrous union, and if you select a wrong implant, and if the timing of surgery also within 6 hours, the fracture of necessity, and if you fix a fracture more than 72 hours, 6 hours to 72 hours is the maximum time I've seen in the literature, and not having a plan B, you will fail and you will create a non-union if you don't have enough equipment. The academic interest, and this article in 1986 has given me good interest of this intra-articular pressure because of prolonged reduction maneuvers with the hip joint in extension interrotation can create intra-articular pressures high enough to create a jeopardize in the blood circulation. So they have created a hypothesis: if the hip is put in extension interrotation for a long time, definitely it is going to non-union, it's going to be avascular necrosis. So on table, we all know this technique, Leadbetter technique, and we all know how to get the reduction and how to achieve the reduction. And another reduction is done in extension. I don't want to discuss all this because we all know this because of the paucity of time. And this is a new technique I've seen in the literature. This is well bending technique. You should become a wrestler and you should follow the wrestling practice to achieve the reduction on table. And last but not least is after failing in closed methods, we have to switch over to open reduction methods. The causes. So first cause is failure to assess the fracture pattern. See, sorry, I'm so sorry. See the how subtle the fracture line is. If the patient is subjected to MRI, the fracture is there, and how subtle here. This is being definitely missed, and this is also. It looks like almost the same. No fracture. So patient is allowed to weight bear, and this got displaced. If we fail to see these undisplaced fractures, definitely the fracture will get displaced and it goes to non-union. And sometimes the CT will also help in finding out the fractures like this. So if the patient complains of pain and if the radiological X-ray shows normal and if the pain continues, definitely we should subject him for an MRI or CT as per a isotope bone scan. And another reason is assessing reduction on table. For this, we should take Garden alignment index. I'm going to discuss that, and definitely Valgus is only accepted next all, whereas our anti-version or excessive anti-version is not at all accepted. So this is the Garden's criteria. So in the AP view, it should be 162 AP view it is slight, Valgus or normal is allowed, and in the lateral view 180 degrees. And if we calculate, we should get at least 3 or 2. So if the score is less than 3, the fracture is reduction is not at all acceptable. And another thing is loss of reduction. If the patient weight base very early, definitely it will go into non-union. This article I found very interesting, done from the Srinagar. Only 2 cases they found, they allowed the fracture and they gave time for the fracture to end for 2 years. But the important thing is you should take a consent and the patient also should ready to wait for 2 years. Another thing is we should know the need of extra implants. What are those extra implants? Buttressing the medial cortex. If the posterior combination is there, we should definitely buttress the fracture. Then only the reduction will be stable. Then only it will be going to good union. And another thing is we should know the new developments in the market for a better fixation, for a better holding of the implant. This is one of the new molecule, new implant introduced into the market. Most of us know. And another thing is younger patients, posterior combination, and we should know this diamond screw technique, superior, anterior, posterior, inferior. So just for academic sake, and I've put one example here. So the 4 screws, how we have introduced and got very good reduction. This is approximately 180 degrees in the lateral view. So the need for the 4th screw, why it is the purchase will be rectangular, and we will have good amount of purchase of the bone. So converging screws, diverging screws, and all were studied. And in some cases where posterior combination is there, 4 screw parallel technique is very much helpful. And plan B, we should know the plan B. What are those? Open reduction, change of implant, and arthroplasty, and excision should be the last of the choice. And if at all there is a non-union, if you doubt a non-union, we should discuss with our seniors without any hesitancy so that we can give good result to the patient. To work up a non-union, we should know the metabolic causes. Already previous speakers have enlightened it, and we should see for the investigation, and we should say for the infection, and we should see the CRP metabolic causes, and we can also subject it for isotope bone scan. Thank you. I think I'm continuing for the next lecture.
So Dr. K. Satish Kumar is going to continue with this topic. One more topic he has been allotted. It's valgus osteotomy, planning and execution.
This was the topic first I was allotted. In the last hour, I had to deliver that talk also. So I'm Dr. Satish Kumar from Hyderabad. I work in Yeshwada Hospital I work in Yashoda Hospital, Malakpet. So once again, I wish you all a very happy Holi. The interesting facts of non-union. According to one study, there was a collected data of 30% non-unions. Because of the lack of knowledge, the non-union rate is increasing like anything. That is why we should have interest to know about the causes of non-union, treatment of non-union, execution of non-union treatment like surgeries. Another thing is vertical orientation of the fracture. Powell's type 3, definitely it will go into non-union. If the fracture is having posteromedial combination, it will go into non-union. If you fix it if you don't fix it properly, and if the quality of reduction is not good, definitely it is going to non-union. Then how to plan and how to execute? Before we plan, we should do a retrospective analysis. Where did it go wrong? And we should prospectively think what are the options we have, how we are going to fix the fracture, how we are going to attain biomechanically stable fracture, how we are going to attain the biology for fixation. And we should see the literature support. Whatever fixation method we are going to take, that should have a good amount of literature support. Otherwise, medical legally we are liable. So while planning, what are the things to consider? Age and physical state of the patient. If the patient is young, replacement may not be the good option. If the patient is old, okay, osteotomy may not be the good options. Of course, we have to take so many things into consider. Duration of non-union. If the head is not peripheral, that means duration of non-union is very high. And we should feel the fracture gap also. If there is any limb length discrepancy, we may have to consider open with osteotomy also sometimes to increase the length. And what are the options we have? We have, if you put all the options put together, we have only two options. Either head salvaging options with osteotomy and a head sacrificing option with a replacement. That can be unipolar or bipolar or girdle stone. So head salvaging procedures are fixation alone. That means to recreate the biology for union. After recreating the biology, to re-establish the mechanical axis, to re-establish the biomechanics. We have all these options. You can fix it alone if the patient presents very early. We can fix it and do an osteotomy. And for the to hasten the union, you can put a bone graft of a cancellous or a cortical, and we can even supplement an osteotomy. These are the osteotomy options we have. So as we discussed, these are all the head sacrificing to address a non-union. Okay, these are all the options to address a non-union. So what are the principles of treating a non-union? So first thing is to get a biology, good biology, and to improve the bone stock. We have bone grafting like vascular or non-vascular. To improve biomechanics, that means to convert a Powell's type 3 to Powell's type 1 or to achieve a minimal valgus fracture, we have a valgus osteotomy. So with those, we have to get a weight bearing axis which is shifted to medially, and the shearing forces will be decreased, and horizontally the compression forces will be increased. So another cause is retrospective analysis. We should see where did the previous surgeon or we have gone wrong. Follow the serial radiographs, because if the patient has weight borne early, definitely it's going to non-union. If the implant was inadequate, it will go into non-union. If the patient have a metabolic reasons, a recent onset of diabetes, or a low vitamin D, thyroid problem, osteoporosis, definitely it is going to be non-union. And the patient is having the habit of taking alcohol or smoking, or a re-injury usually happens in alcoholic patients, definitely it is going to non-union. If we address that issue, next time if we take care of that issue, definitely it will go into union. Because we don't have a control Z option in the life, definitely we should retrospect, and prospectively we should execute our plans so that the patient will get hip union, so that his rest of the life will be very healthy and happy. The prospective thinking, what is the prospective thinking? What are the implants I have, how much efficacious I am to perform the surgery, and how much knowledge I have, and when to make the patient bear weight, how to execute it on table, and how to prepare preoperatively with templating, all those things. Definitely, we should have an idea. Like the Steve Jobs said, if you are having good thoughts, the thought will only drive you. You don't have to do anything. And we should take the enough amount of literature support. So this article, I have also put it in this thing. If you wait for 2 years, these two fractures were united. But are you can you wait for 2 years for every fracture? It's an question, $1 million question. And we should go through the articles like Valgus, Intertrochanteric Osteotomy. I've put some articles. This is how a VIT or Valgus Intertrochanteric Osteotomy will be performed. A non-union fracture, and below the lesser trochanter, they have made a osteotomy and they have refixed it, and the fracture has united like this. What they have done is they have converted shearing forces to compressive forces. And what was the limitations of this study was conversion of this to a THR will be very difficult, but union rate was only 90%. If you take this as your management tool, these are the limitations of the study. And another thing is only one case has been reported in the literature. They have done a valgus sliding subtrochanteric osteotomy. So they have slided the fracture to make it the fracture, vertical fracture to a horizontal fracture. Luckily, it has united after 6 months, and this is the 3 years post-op X-ray. This is how they have executed and they have planned this thing. But what they have concluded is we do not recommend this technique as a primary fixation for Powell 3. Okay, so the acute fracture fixation still adheres to the principles of anatomic reduction with rigid fixation. Even though this was a very good osteotomy, they are not recommending it for acute fractures. And another thing is, this is also a very good article published in 2008. So what are the possibilities and limitations of various treatment modalities? What they have done is they have studied refixation, they have studied valgization osteotomy, they have replaced it with a prosthesis. This is how a valgus osteotomy is executed. First we have to fix the fracture. Then we have to calculate the amount of wedge to be removed, and after wedging, the fracture will become more horizontal so that the forces will become compressive forces, and we have to fix it. Then for a period of time, fracture will unite. And in young adults, these are the recent concepts. These are the available options we have. Powell's osteotomy designed in 1935. Then Dixon's geometric osteotomy. The non-union viable neck of femur is the indication that is very easy to perform. And another is McMurray's osteotomy. Another is Sean's angulation osteotomy. This is made at distal to the lesser trochanter. And these are all the muscle pedicle bone grafting. The last option is arthrodesis. So this is the new technique, modified Powell's intertrochanteric osteotomy. The principle is only one: make the forces to compressive forces from a shearing forces. Make the fracture horizontal so that the fracture will unite. Create a good biology. If the blood supply is lost, put a vascularized fibrillar graft. If the blood supply is good, put a non-vascularized fibrillar graft. If the fracture line is vertical, make it as horizontal as possible. Then only the fracture will unite. Either you can put a execute. So make a template of the fracture and like this, then you can execute very easily. So calculate the amount of wedge to be taken and calculate the amount of screw to be put, calculate the amount of plate to be put. So if you take a 20 degrees of the wedge, that 55 degrees fracture is becoming a 30 degrees, then it will become a horizontal fracture. After final fixing, this will be like this. The fracture is united very nicely. So don't neglect medical legal issues. Don't try to take a consent properly. So what we lost, if you restore it, definitely it is going to unite. Whether we lost at biology, whether we lost at biomechanics, or we failed in fixing both. If we retrospectively analysis, and if we have a good literature support, and if you have a good surgical skills, definitely a non-union will be addressed very, very nicely. So I thank my friends who have started recently the UPA Super Specialty Hospital. I wish them very good luck, and thank you for the organizers giving me the opportunity. Thank you all.
And thank you, Ashok, Satish. There
Sir.
were nice talks on a very difficult subject, fracture non-union neck femur and also valgus osteotomy. Just a few questions. The students, we have the habit of putting skin traction for all fracture neck femurs. To advise still the skin traction for the neck femurs, acute fresh fractures.
Acute fresh fractures, we would like to fix as early as possible, sir. If there are any other comorbids, definitely we put them on traction to relieve the muscle spasm so that the reduction will be on table will be very easy.
Okay. Then, second question is, do you still advise lead butter technique and this 90-90 traction technique?
No, I lead butter technique only I use, sir. 1990 I don't use.
Okay, regarding the second topic, what is your indication of primary valgus osteotomy? Primary valgus osteotomy in the fracture neck femur. You said for non-union, but for a fresh fractures, what are your indications for primary valgus osteotomy? Do you do?
Fresh fractures usually we don't only for non-unions only.
Okay, thank you. And thank you, Satish, for your nice words. We are also honored for chairing your session. Thank you so much.
Thank you.
Thank you. Thank you, sir. Please be on the dais. I request Dr. Subramania Rao sir to come out to the dais to hand over the token gift to Dr. K. Satish Kumar. Thank you, Dr. K. Subramania Rao sir and Dr. K. Satish Kumar sir. Let's proceed with the next seven.
Now may I call upon Dr. Jawahar Jatwa sir to just give his talks on two talks are there. Non-union IT fracture, how to prevent and how to treat. And non-union subtrochanteric fracture, how to prevent and how to treat. So please, sir.
This is forward, sir. This is for the point.
Welcome to AP and welcome to Ongo, sir.
This is forward. This is forward. And that is the point. The light sign is the point. So if you want to move around, you can take that.
So thank you very much for this opportunity. I'll be talking both the lectures one by one together with the permission of chair. So I'm very happy over here to come. Is it going ahead? Not. This is not working. Okay. Is working? Okay. So thank you. I have nothing to declare about this. It's not going ahead. Okay, I do not use this. Okay. So make it again back because the problem is, no, even this thing should work. I'll just try with this. This is not working. No, it is too much ahead. So this is a different one. Go back, go back. This go back in? So what I'm going to ask about is that please come to my city of Ahmedabad. We are having so many good infrastructure. And I have a big hug for all of you to call me and invite me over here to see this fantastic academic activity as well as fantastic organization and the venue. We all know that two-part fracture is not a problem, but the problem starts when it is the unstable three-part fractures, where whatever the implant we do, there is going to be malunion or non-union. So what I'm going to talk about is something where there are some challenges and you get the best of the results. So that is a modified undernailing with CC screw. So we are talking about the prevention aspect of non-union and malunion. So my talk will include so many such subjects, which is primarily about this particular technique, its complications, some of the illustrations which I'm going to talk about. So non-union, we have got in all these different definitions, but for us, very important definition is a fracture that has no potential to heal without further intervention is a non-union. So we know that the burden is very high, particularly the malunion. And there are some various treatments which you already heard, but that malunion is again a very important aspect because there are some good literature where it talks about that there is a 22% out of 204 patients having a mechanical failure, up to 70.7% mechanical failure, 7 to 20% some different parts of complication, and mechanical failure could be up to 16.5%, where 75% because of the cutout from the head, which is very, very important to understand. So what is malunion? Malunion is not necessarily only malunion. It could be mal reduction and union or loss of reduction and union. So we need to see that we also want to avoid malunion, which sometimes so much problematic. And there is also a terminology called delayed union. And I'm going to talk about defective union as well, which is a part of this. What are the causes? We know number of causes speakers have said, but primarily it is instability or ischemia or infection. And there are so many other causes we know. What we are interested today in my talk is instability, which is giving us a big problem. So what we are using is undernail plus CC screw. And this is a public, literature which says that when there are multiple nails, it is 18% stronger than a single nail. And this Japan Orthopedic Association in 2002 said undernailing is an easier, faster, earlier, larger, which promotes callus formation. Kemp says undernails lead in a large majority of cases to a solid fixation. We cannot avoid this particular publication where 2,137 cases with no case of a non-union, no case of a broken nail. So what is happening with this? So various successful additions we have to make because there were some complications in earlier studies. And this is what I'm going to share with you, that it is not the old undernailing technique. Many things have happened. What is the challenge? Challenge is that we need to have a best of the reduction, which is the anteromedial border, neck shaft angle, anteversion, and something to hold proximally, something to hold distally, something to connect that, and with having a controlled collapsibility. And it added to that is the complexity of osteoporosis. So that is the challenge we know. Now, there is a constant morphology of any of the intertrochanteric fracture. There is always an intact head and neck, and there is always intact a subtrochanteric and distal shaft. So the principle is very simple. Get best of the reduction with whatever the technique you can do, then press fit hold proximally, press fit hold distally, and the job is done. So that is the basic principle. And the elements of this particular fixation is part technique reduction, 7 mm interfragmentary screw, then 3 contour nails, and then turbo screw, which is again 7 mm screw, and a distal U-pin lock. That is going to give best of the rotational stability. Now, comparing with the other implants, we know very well that all the implants which may occupy head and neck up to 37%, while undernail occupies with CC screw 54%, and that is the whole which is possible. And visually, if you can see, all other implants are occupying some part of the head and neck, but undernails with CC screw is a larger area which is occupying. More than that, it also increases the compactness of the medulla in the neck. And so total of 27.5 mm metal is there to hold neck and head of the femur. There is nothing like an anti-version in any of these implants. Only undernail can give rise to this. So what I mean by anti-version, this is no anti-version, no anti-torsion. This is anti-torsion, and this is precisely is anti-version, which is at the intertrochanteric reach. So that is very important for us to know. So when there is a posterolateral slit, you need to have some implant which can go like this, But this implant is not possible having a cover which is anti-version, or another implant with a screw that it is not possible it can have a cover like this. So I have no such possibility. Only endonail can do like this, especially when there is a posterolateral split. You can see you put implant like this, you are going through the fracture. So what we need is to pass interfragment screw from the intact anterior part of the lateral wall and then to fix with these 3 endonails. So the problem of lateral wall issue is now no lateral wall issue. So that is the beauty of this particular assembly. And we know that the rotation stability, which is controlled by fanning, elastic hook clamp, screws, and especially the contoured nail, which is a very, very important aspect. The turbo screw is basically displacing the tip of the nail. And that is how it's going to push it. You can see very well the animation. And that is how it increases the stability as well as the rotational stability. What exactly happens? This is a dramatic aspect. You can see the turbo screw is going to push one of the nail. It is going to make them apart. That's why it increases the stability in the head and neck. We know that when we go to the proximal femoral nail entry, we are going to harm vascular structure as well as musculature. And a lot of literature is available that up to 53% of the patient can have a substantial injury which can cause hip pain. With a bar sport, there is no bar sport available. You are going to damage it, but in case of an endonail, we are not touching. It is the advantage of this technique. So effectively, old problem of external rotation, weak fixation, everything has been very much clear by these modifications, which I'm going to bring. Now let us have a typical operative setup. We need to have CT scan of all intertrochanteric fractures. Then only we know what exactly is the morphology. These are the instruments which we use, and this is how the operation setup, where from the lateral side of the limb, surgeon passes the interfragmentary screw, and then it goes on the medial side to pass the endonails. And this is how it is done. Now let us see how we are going to take the operative steps. But before that, let me talk about that conventionally we are using guide pin which is 2.5 mm. Instead of that, we recommend to use 3.2 mm dead tip pin so as to use 7 mm screw. So it goes straight into the trajectory which you want. It does not go and does not make. So this is an incision on the medial side of the femur, lower end of the thigh, and this is how you are going to just elevate the vastus medialis from the posterior intermuscular, which you cauterize, and then you make a precise fenestration on this particular part with a precise area where you can make such a good hole to pass all the 3 nails, and actually it lies like this at the end. Most important part is 2 sagittal curves and 3 coronal bands. All these things are very, very important. With that, each of them has its own role to play, and then only you are going to get the results. So this type of bending, the distal and the anterior version bending, which is very important, and you need to have an extractor to take it out. Then you make a neck shaft angle particular band, and then only it is a fit to pass as a best of rotational stability. So this is how it's a curved nail which is passed through this particular hole, and it is hammered, and you have already passed interfragmentary screw, and then one by one you try to pass the nails, which goes into a different direction, and you actually get the final fixation like this. And the practice is very important. At the end, you just suture the vastus medialis, cover all the implants, and suture deep fascia as well, and then you put a data dressing so that there is no more. Sometimes we use this particular distal U-pin, which is made out of 1.8 mm K-wire, which is cut like this, and at the end it passes through the eyes available of the nails, and then you are able to just punch it, and it fixes so well. It is not for only backing out of the nails, but it is also for the rotational stability. Here you can see the sequence could be interfragmentary nails and turbo, or both the screws, or one screw, or no screws, only the nails. So it could be anything. Now, few of the illustrations, let me go through. This is the case. 74-year female. Look at this. Second day walking is possible because of this particular implant. There is another case where a 68-year male, which is fixed union without loss of reduction. That is what we wanted. Not only non-union, also not malunion. You employ all smart techniques, try to use and get the best intermedial reduction. So here we are using this particular pin, and then you are going to get the best of this. Each and every part of this, which I have talked about, play a big role to get the best of the results. And sometimes if you are not passing the nails properly, then there is chance that you have to pass turbo screw, and that turbo screw will be a good bailout, and it will go, even if it is a minus reduction, it will go for the best of union. Good bone, good implant, good method, that means good results. And this is what you can achieve with this fracture, which is intertrochanteric as well as on the same side, fracture of the tibia. Both were treated with endonails. And this is what I call it as the happy fixation. Even if it is two fracture, he's having a full movement. There is an interception which we have found out. And these are the cases where it's difficult to get the reduction. But after reduction, if you put like this, what is very important is that even 145-degree of neck shaft angle can be accommodated with this particular implant, because other implants will not be there. Here, the implant is as per the reduction and not the reduction as per the implant. And such a very bad fracture is a versatile assembly to fix such fractures because of the elastic recoil and micro motion. And you can see very bad fracture, which has been fixed so well and is going to give you best of this because of the precise contouring. Cases we have found out with a very high morbidity, and with that also it is possible to get, when you use this particular technique, and union in time, no loss of reduction, no digital migration, and anatomy restored. Look at the whole diagram of the anatomy. Everything is restored, even though it was a very bad fracture. Here you can see at the as a summation, good reduction, press pit hole proximally, press pit hole distally, and we have a profound observation that there is always a timely union. Let's talk about forget lateral wall fixation, where there is always a possibility of a lateral wall deficiency. Here is the case where there are so many fractures. When you put this underneath, it actually works as an intramedullary anatomical distractor. And look at the final union of this multifragmentary intertrochanteric with subtrochanteric fracture. And this is how patient gets a full movement, smile and squat, no proximal nail entry, no open reduction, no tension band wiring, no buttress plate, no restored, and there is a best of the restored anatomy and full power grade 5 functionality. Here you can see unstable fracture. Again, it has gone for a very good fixation. You can see very bad fracture, which has gone with the best of the union. And the last part of my talk is about the subtrochanteric fracture, which we know there is a good cyclic varus force. On the other side, what we need to do is create a large dynamic cyclic valgus force by this particular implant. And it comes when you pass only medial side and the nail. But once you pass from the lateral side, it prevents this varus collapse. And this is only possible with this particular implant. I don't know what happens at the age of 18. On the 18th birthday, suddenly we think now patient has become adult, so we cannot use elastic nail. So we have to think of not only published science, but practice science. So ask your superior, how do they do? Do not depend on the published science. This is a very bad, unstable variety where it can be fixed very well and patient is able to walk. What is very important is that combinedly, this particular assembly creates such type of an implant which occupies the whole medulla, and there is no possibility of translation or a loss of reduction. And this is, I call it as a happy fixation. So friends, there are so many cases which go on looking like this. And this is a very good modality, especially after these modifications and all these particular changes which we have made. And you can see all these fractures which are otherwise highly unstable may require more than 1 or 2 or 3 surgeries, but they go very well. And we know in all of these conferences, there is always a one case which shows that which is a subtrochanteric, and there are multiple surgeries which are going on. And there is a very common thing, and I feel so much unhappy that there is a good methodology available with always one single primary surgery. You are going to get union. There may be some malunion, but not in all cases. It's only in 2 to 10% cases. Otherwise, you are going to get the best of the union. All type of different fractures, you can see they have gone into a very good union. it is something like you do not feel so much afraid of that these nails are not going to hold well. It's an experience which is going to give you more confidence even in such fractures. Even if the fracture is with the old implants, it can accommodate all implants and any type of combination which goes very well incorporated in this particular methodology. There are some cases where there is a real challenge of some delayed or late presentation where also you can use this type of technique. And there are some cases where there is already a knee replacement has been done. And with that knee replacement also you are able to pass this nail by the side, which you are going to see some of the cases. And these are the cases where you can see once you have the skill of contouring the nails, you are so much confident that anything can be fixed very well. So there are multiple cases which I have shown you, even with a very wide variety, with the TKR done below and with a highly unstable areas which you can see on this cases. More important aspect is that once you know, then you can prevent complications. In earlier cases, when we were using all these modified techniques, we had migrations, we had some sort of a problem with a loss of reduction, but we found that with a turbo screw, which can be prevented, and all these fractures where secondary it is done, this can also be occur, but it is always on in the earlier cases. But sometimes when patient is not able to cooperate, there could be some problem. But U-clip also has given sometimes a problem with the irritation. Now, this is the fantastic case where intertrochanteric fracture fixation was done with a highly morbid patient, and she fought again after a year. What is very important with this particular implant, it fixes whole femur. There is no stress riser. So what happened with the second fall, only the clip came out, which you can see on this clinical photo. So I just remove the clip. There was a prevention of the second fracture because of the second fall. So that is something very interesting. And sometimes there could be a bailout by end nail. This is a case which was having an unstable variety, which was treated 3 times. There was a fixation was done, twice bone grafting was done, and ultimately it went into a non-union. So what we did in whatever the available position, we passed this end nails to fix it. It went into a very good union, although it is not 100% in a position, but acceptable malunion, and this is how she is able to walk. What is very important is 5th surgery, 3 years in bed, wife of a renowned family physician is so happy to go with this technique and get up and above. This is what I want to talk about, the defective union. A case which was fixed like this, there was a very good union. And after 3 years, patient was having some pain, so implant was removed. And again, with a trivial trauma, I got a fracture. Again, the same technique was used, very good union. After 3 years, implant was removed. Again, she went up into another fracture with a trivial trauma. And thereafter, series of operations are being done. And this is what has happened, that there is at present, even after 7 months of last surgery, which is added with so many implants, there is a little sign of union. So friends, at the end, let me tell you that up till now, there were some terminology like rigid fixation, flexible fixation, motion law fixation, but now I'm coming out with a word or terminology called happy fixation. So what do I mean by happy fixation? It preserves the biology. Incision is in the healthy area. No intra-articular entry points, minimal surgical trauma, smart indirect reduction, exceptional press fit grip with dynamic inside-out forces, which is very important. No stress risers. Implant as per the reduction and not the reduction as per the implant, which is very important. Micro motion induces callus, control collapsibility, and there is rarely infection, non-union, or fat embolism. I again emphasize that implant as per the reduction and micro motion, which are very important aspect of this assembly. I thank you very much, all of you, to hear me patiently. Thank you.
Thank you so much, sir, for exactly finishing on time. Thank you, sir. And it was really very surgeon-friendly technique. But two questions from me, sir. And then how do you control this, any incidence of proximal migrations or penetration to the joint?
That is what I said. So number of around 55 cases, there is no migration now because of the technique of contouring, because of the distal clip, and more because of the turbo screw, which I said is going to change the path of the proximal screws inside the head and neck. So it's going to hold it. It's not going to allow it to slide down. So all these things which has happened in from 2008. So by now we have around 14 years of experience. So all those things which were England and Europe, many of the countries, developed countries have started applying for such particular tibia fractures and substable fractures. They are using this. Very important aspect is that do not go with the myth there is always a distal migration, because you have been taught in your residency. Your professors have told, but you have never seen. And this is also available on YouTube. You can see number of cases. We have got now 3 publications. We are now going to go in more and more of publications for this.
And how early you are allowing weight bearing, sir?
Weight bearing is
For,
something which I-
any criteria to allow weight bearing?
Yes, so the criteria particularly for young surgeon is if fixation is good, weight bearing is immediate. Weight bearing is never ever dependent on any implant. The surgeon knows that I have done a very good reduction, is a stable reduction, I have put a good fixation, so start weight bearing. In case of an osteoporosis bone, weight bearing can be delayed by any of the implant. So weight bearing is not dependent on this particular, it is dependent on the morphology of the fracture, the reduction pattern, the stability, and the way you feel the final tightening, the final blow of your knee. And then you know, yes, but it is as equal to as other implant. Weight bearing has been started. So there is not a problem in such cases.
What is the average time you took, sir? But in your hands, average time, just to
Yes,
like to know.
yes, sometimes it is, usually it is about an hour or about 90 minutes. But sometimes it happens that multiple fragmentary fractures, we take more than 2 hours. Have a hook to work upon. So you pass a nail and indirectly you just try to maneuver and get the reduction. That is the best part of it.
Thank you so much, sir. Anyone? There are no more questions. Any questions from the delegates? From the neighbors? I would like to wait for the comments of Shivashankar also, sir, sometime later.
Yes, yes.
Next day, tomorrow, day after tomorrow.
Right, right.
Thank you so much, sir.
Thank you, thank you, thank you.
Thank you, Dr. Jawahar T. Jaitwa, sir. Kindly be on the stage. I request Dr. Subramania Rao, sir, to come and present him a token gift. Sir, I shall give you a certificate by evening, sir. And sir, Dr. Y. Nageswara hasn't come yet, sir. So let's proceed with the next topic, sir. Dr. Srinivas Kasha. So I shall announce Dr. Srinivas Kasha. He is going to present on non-union distal femur. His timing will be 10 minutes.
I am very happy to invite my friend, Srinivas Kasha. Welcome, Srinivas. And we are eagerly waiting to listen to your talk. We know you are an excellent speaker with lots of experience. Please.
Sir, thank you so much, sir. At the outset, I must thank the organizers for giving me this opportunity. And if it doesn't work. Yeah. So my topic is non-union. Right. Non-union distal femur fracture management. So I will take you through some of the cases with some message in each case. So although you got so many advances in management of distal femur fractures with various implants, still the complication rate of non-union is around 18 to 20% in various publications. And distal femur non-unions, they presented, can you just open this? Yeah. Remove it, yeah. I just want it to be open. I don't have visibility here. So either it presents with a persistent pain or it might present with a deformity, and it depends on. Okay, sir. Yeah, fine. Of course, a painful limitation of the movement. And yeah. So you've got various factors which might lead to non-union, which are patient related and sometimes fracture related, and surgeon related factors which are which can be controlled by surgeon, by which you can probably prevent complication rate, is your plate length, plate working length, and the screw density of the fixation construct, and the use of titanium or stainless steel, or whether it is a local made or an imported. I'll tell you why I mentioned what kind of implant, and cortical reduction, which is very, very important. So the important thing is reduction and the use of dynamic fixation. Even if you are using a locking plate, still you can dynamize it and get some compression across the fracture site. We know all the non-unions are, management depends on whether it is infective or non-infective. I'll take you through both the cases, and metaphyseal and coronal plane, OFA kind of a fracture, which is more common nowadays because of the high energy trauma. So the medial condyle, I just want to take you through very important salient features during surgical fixation, which are anatomically relevant. So that is, the medial condyle extends further distally than its lateral counterpart, resulting in a valgus limb axis, which is around 94 degrees on the medial side. And the shape of the distal fragment is trapezoid, where it's like a wedge, where the anterior part is narrower and your posterior part is wide. And at the same time, lateral side, you got a slant of around 10 degrees, which should be kept in mind while we use a distal femoral locking plate. And the screw construct, if it is parallel to the ground, is going to be at the narrowest portion, and it may not give adequate purchase in the distal posterior medial condyle, which can be improved by having that plate abutting onto the lateral condyle. I'll just something like that, which extends its purchase onto the posteromedial condyle, and at the same time, variable angle plates might increase the purchase up to around 15 degrees into the posteromedial portion of the condyle. And various biomechanical studies have demonstrated that the axial load strength of lateral lock plates are superior to condylar or intramedullary nail, although torsional comparable with them. Either I use a straight rod, you can use a cautery cable to restore the axis during surgical fixation. And I'll just take you through a few examples. 60-year-old male, 6 months post-operative case, planned. Of course, any failure indicates it's a ununited fracture. And when you go inside the fixation, the point which I want to make in this particular case is to get an anteromedial contact, cortical contact restored. So which is indicated by the white line. And of course, excision of the fracture ends or resection of the fracture ends to the vascular end, portion and restoration of that anteromedial angle will give you a cortical continuity on the anteromedial side, and that will be most of the time sufficient to withstand the stresses, and that is the fracture healing after an year. So excision of this sclerosed fracture ends usually result in disparity in the diameter of the distal femur, and as it is a funnel shaped bone at the distal end. So if you can see in this particular picture, the preoperative X-ray and the postoperative X-ray, where almost transverse osteotomy kind of a fracture restoration was done, and medial cortical continuity although restored. So you should not use a friction kind of a plate on lateral side, which obviously pulls your proximal fragment and takes the fracture into varus, and you lose the reduction and medial contact also, which has to be maintained either by using a locking screws all through, or use something when you put a locking screws in between the plate and the bone. So I want that to be, I'll just take you through this particular example. So that is the fracture, and when you do excise the fracture ends, you end up with a funnel shaped situation where your cortical contact is not good, which can be restored by medializing the distal fragment, lateralizing the distal fragment and maintaining the space between the bone and the plate. And that is 2-year follow-up of the same patient. Here is another example, 30-year-old male operated elsewhere 2 months back, failed. So failure within 2 months means there should be, some fixation problem. So here in this case, let us see the CT scan of the same patient. If you see your anterior condyle, anterior part of the condyle is completely intact, whereas your posterior condyle, it's a bicondylar fossa, which was not addressed properly, and that has resulted in failure. I'll just show you the intraoperative picture. You can see the shaft is in continuation with the anterior condyle. It's only the posterior condyles which got displaced and which doesn't have any hold with the plate which was used from lateral side. So that is during surgery. That was the posterior condyle, and which was restored and put a buttress plate on both the posterior condyles. So so that's how the fixation was done. That is after immediate post-operative, and you can see the CT scan. I just wanted to show, because assessment of the fracture and fracture plane is very, very crucial when you plan for a non-union fixation of a distal femur. And that is after a year of outcome, once the fracture has healed. So here is another example, 2-year post-op polytrauma, initial 2 surgeries. So patient presented with this particular picture, and intraoperatively, if you see avascular ends, the sclerosed ends, which obviously won't allow the fracture to heal. So that has to be excised, and vascular ends are the prerequisite for any fracture non-union, not only in distal femur, but anywhere else. And it was fixed, although patient were given options of limb length restoration. He chose to have a fracture fixed and have the knee range of movement, and shortening he wanted to accept. In this case, that was the fracture after healing. So another 50-year-old male, ESR and CRP elevated, presented with this picture within 2 months again after the fracture. So you can see the screws are backed out, and if you see the CT scan, okay. So let me take you through intraoperative picture. Your whole lateral condyle is become like a void. So after clearing the fracture ends and made a distal femur transverse cut, just 2 minutes. And it was managed with 2-stage procedure initially, with adequate debridement, primary fixation, and antibiotic cement spacer, which initially gives a mechanical support and releases antibiotic, and it induces a membrane which is rich in growth factors which are useful for graft revascularization during the second procedure, which is known as mascule technique. The same thing. So 2 more minutes, sir. So the same thing with the fibular strut, managed at second stage surgery, and the same mascule technique can be used in various recalcitrant non-union surgeries associated with infection also. And medial plating and bone grafting is a standard procedure which usually results, the results are excellent after adding a simple plate on the medial side. This is just an example. And you have got plenty of literature which can support addition of simple medial plate after a non-union results in fracture healing. So here is another example of the same thing, 2 years post-op. And this I just wanted to show, because any gap in the distal femur or in metaphysis, especially in the cancellous zone, usually results in non-union. In this case, you can see a fracture went into non-union even after 1 year post-op. And so fracture ends were freshened and used a stable fixation with the extra addition of screw, which has resulted in fracture healing. And another last case, sir, with 45-year-old, multiple surgeries, managed with Elizaro in the past, and which has also resulted in failure of the fracture, and persistent infection was there. In this particular case, limb reconstruction system was used, and antibiotic cement spacer after thorough debridement. Later used cement spacer was removed and bone grafting was done, something like a mascule, which has resulted in fracture healing. The take home is lateral locking plates are highly successful, although it has got a failure rate, especially when you have a medial cortical contact which is not adequate, or if you have a gap at the medial cortex. And medial cortex gap, restoration of medial cortex continuity either by putting a plate or by lateral plate itself, and having a proper cortical contact by dynamization will result in significant fracture healing rates. And of course, infected non-unions, 2-stage surgery. Variable angle plates have got an advantage of having targeting the screws into the good bone stock area, wherein in failure cases, most of the times you have got a loosening of the screws, which result in very meager space where you can actually put your screws, especially on the anterior medial side. So you have a significant void wherein your screws are to be directed more posterior. Thank you.
Thank you, Srinivas. It is an excellent talk. We know you as a peri-vestibular surgeon, but you know you equally do a lot of good work in trauma also. Thank you so much. And what is your approach in that posterior plating? The same lateral approach, or you took another approach?
Medial and lateral, sir.
Yes.
Medial and lateral approaches. Yes.
We saw 2 plates posteriorly.
Yes.
Okay. Then what is the primary indication for medial plating? Yeah, of course, non-union you said, but when do you use the medial plating in primary fractures?
Yes, sir. That's a very important question. Medial, if you are having any gap on medial side, so it is better to go ahead, especially in transverse fractures. So if it is comminuted and if you have a good bone strength, and you have a good implant which can sustain loads for a long time, it is okay, you can just put a plate in case of comminuted fractures. But in case of a transverse fracture with a gap, most of the times leads to a non-union.
Yes, yes. And then you are a plater, but do you ever use the DFN for distal femur fractures?
DFN.
What is your indication for DFN?
Sir, a It is for metaphyseal fractures, not intra-articular fractures. So although there are some extended indications, but I never use it for any intra-articular distal femur fracture.
Okay, it's a wonderful talk. Thank you, Srinivas.
Thank you so much.
Congratulations, you are become TOSA secretary recently.
Thank you so much, sir.
Congrats.
Blessings.
Thank you. Thank you, Srinivas Kasha Garu. And I request Dr. Jay Shekhar
One
to
question,
come and,
please.
to come and hand over a token gift to Dr. Srinivas Kasha. It's a center. Jay Shekhar. Thank you, Dr. Srinivas Kasha. I request Dr. Malyadi Naidu Garu to come over to the dais to felicitate our organizing, our chairpersons, Dr. Professor Ashok Kumar Garu and Professor Uday Kumar Garu. So thank you, Professor Ashok Kumar Garu, Professor Uday Kumar Garu, Dr. Malyadri Naidu, and Dr. Jay Shekhar. Now, we are going to a very important session of honoring our Dr. late Etirazul Naidu Garu. This actual CME is going on in his honor and in his memory. And I request the state body, Dr. Naresh Garu, Dr. Durga Prasad Garu, Dr. Malyadri Naidu Garu, Dr. Jay Shekhar Garu, to come on to the dais, please. And all the scientific sessions from Prakasham Orthopedic Association, the scientific organizers.
Good morning, everyone. It's customary for us to honor Professor G. Ethirajulu Garu on first day of CME, which is Professor Ethirajulu CME. I request our Honorable President Dr. Durga Prasad Garu, Shekhar, and Scientific Committee Chairman Amarnath Reddy Garu, and the Senior POA Orthopedic Association member, Professor Prasad Garu, to come onto the stage to felicitate and garland and honor the Professor G. Ethirajulu Garu.
To all the newcomers, Dr. G. Ethirajulu Garu was the first orthopedic surgeon, is the first man to get a MS orthopedics degree from Andhra, our Ossapcon General Secretary, Dr. Naresh Garu. Sir.
Can I have this slides please? Yeah. Slides on చేయాలి. మీరు కూర్చోండి. I'm a ఇదేనా? So Professor Ethirajul Garu joined government service as assistant surgeon in 1948 and worked as a tutor in surgery of state of Andhra Pradesh. He worked as a tutor in surgery at Andhra Medical College from 1950 to 1954. He deputed to undergo training under Professor Swami Madras for 6 months. Later, he was promoted as a lecturer and head of the Department of Orthopedics, subject to USA for higher studies at